Yeah. You guys put all of your paperwork aside to give Annette her attention.
Oh yes, I must have full attention. Yeah. You.
And you can work on it later. I'll accept it today. Okay, I'm here until 2:30, and I'm going to work at Quiet Oaks, so if you need a little more time, that's fine. See, I'm flexible. I'm going to turn the light off just a little.
So somebody at the last class was sleeping. So I just, I thought, wouldn't it be nice to, and he was kind of like, ooh, really kind of yawning, and I thought, God, wouldn't it be nice to have a hammer just smack it down on the table, while he was had his eyes shut. So. They don't look like they're going to sleep.
Since you said he, they might narrow it down.
Oh yeah, I teased him in the hallway this morning. Yeah. I don't know his name, but
You?
he's got curly hair, baseball hat, kind of goofy. Yeah, he was sleeping. But I tell y'all.
This is Inga, and Gina's back. We're ready to go.
Don't worry that we were waiting for you guys. Not a problem. Don't be embarrassed.
For your abdominal assessment, you have till 2:30 today, no later, so we'll give our attention to Annette. I work with her at Quiet Oaks. She's been a nurse a lot longer than I have, so.
27 years, 30 years now. So I started as an LPN, and then and then became an RN, and then worked the bulk of my career at the Minneapolis VA. When I started as an LPN, we wore, well, she knows all this, she's heard it before, but we smoked in the hospital, patients and staff. We wore hats, dresses, white tights, leather shoes, and our nursing pants. So that's kind of what we wore. We had steel bedpans. We didn't have pumps. We had drops per minute. So you watch the drops for a minute with your watch. So that got a little bit tricky with some of the meds and stuff. Do you remember that or no?
I remember learning it.
The runaway IVs.
Room. Oh shoot.
You're like, oh my gosh, the bag is empty and it went in 5 minutes. So that was kind of scary, yeah. So, not too good. I'm sure there was some bad outcomes to that. Anyway, so I've got the unique perspective of being a registered nurse for so long, and then also having a complex medical history with ileostomy. I have an ileostomy, and we're going to go in. I haven't changed a bag for 6 weeks, so then we're going to go in, and you guys are all going to change it in there. So, no, I'm teasing. Okay, so oh, somebody else is late. What is your name?
Emmy?
Emmy's late.
Emmy's
Don't be embarrassed that you're interrupting the lecture. No. I'm teasing you. Okay, so I started out in 2000, you'll have to remind me because I'm forgetting my own history. In 2012, so in 2005, I ended up in a terrible situation. I had a hysterectomy, and I went into the clinic after the hysterectomy, and a doctor said, we're going to flush out a clot around the cervical area. I had a clot there after surgery. He said, we're going to flush that out with some peroxide. And my nursing hat on, I said, I don't know if that's a good idea. Oh, we do it all the time. So he took a syringe full of a Foley catheter and placed it in the vaginal tract near the cervical cuff where there's an incision, and he pushed in the peroxide. Well, unfortunately, it went through into my peritoneal cavity. So I complained about right referred shoulder pain, which I'm sure you've talked to them about, the right referred.
I haven't. Have you heard about it?
Right.
Someone that has laparoscopic surgery, the air in the abdomen causes referred pain.
So I had this right referred shoulder, which I knew was a problem, but nobody was, of course, listening to me. And they said, well, you can have some discomfort, so just, relax and go to your car when you're ready. So I was getting dressed and everybody went to lunch, and I didn't know that the clinic ended at lunchtime. So then went into shock. I was in the clinic on the floor, and 2 hours later, somebody found me screaming in there. So consequently, I had a peritonitis, severe peritonitis. I was in the ICU, and also they had to take me to surgery for about 4 hours and rinse all that peroxide out. Through the years, my colon doesn't work. It stopped functioning. Peristalsis wasn't there. Lots of laxatives wouldn't work. Lots of pain. And so I ended up having a first procedure in 2012, which was a temporary ileostomy to take out some of the colon and then kind of see how I would do with it. And then reverse it and then do a trial of seeing how I would do after that. This is the loop ileostomy that was done in 2012. And this is a temporary ileostomy, and it's broken, it's kind of halved between the large intestine and the small intestine. So you have the large intestine opening here and the small intestine here. The thing that's not real good about that, it can't be used sometimes people use them permanently, but it's not real ideal, because it's hard to fit an appliance on here. Also, one of them leaks. The small intestine one leaks a lot. Then this has mucus coming out of it all the time. So it's a lot more management and care. So then after that was done, it was put back together. Then I ended up with a abdominal wound. Did you want to put that one up? Yeah. So after the reversal, I ended up with this major abdominal wound, which took like 2-3 months to pack and heal.
So it was closed and then infected and then
Yeah.
opened up again?
Yeah.
Okay.
Yeah. So that required a lot of packing and a lot of care at home. There's another picture of it. Do you want to go back to the back? She gets to be my assistant, and she's in charge of me, I think, a little bit at the Quiet Oaks, aren't you? Oh, yeah. Yeah. Okay, so then, after it was reversed and the wound healed, then I started having the same problems I had before. So then it was decided that I would have a permanent ileostomy, which is the end ileostomy right here. So the large intestine is completely removed, and then the small intestine is brought out through the wall. And that, of course, with ileostomies is pretty much just liquid stool. It's not. And one thing with patients like that is that I find myself getting dehydrated really easily because you're losing your liquids right away. In the colon, that's how you get hydrated, is that the stool, the fluid gets recirculated and removed from the stool, and that's how the stool ends up coming out through the large intestine, and then you get some of that fluid back. With an ileostomy, you don't. So I end up kind of getting really thirsty, having to carry liquids with me all the time. While I was in the hospital and had the permanent ileostomy done, I got out of surgery, and no, you can put up that stoma, that discolored one. One of the biggest problems with risk factors with ileostomy was stomas, either being colostomy stoma or ileostomy stoma, is necrosis. So I left the hospital in this color, this dusky color. Now I brought it to the attention of my doctors and nurses and said, I don't like the color of that. The other thing is that it wasn't draining properly. So I had to use a tube, much like this one, to drain it while I was in the hospital. And that just didn't make sense to me. But everybody's like, well, sometimes it can look a little like that. So what are you going to do? I got discharged and went home. Then that turned black, all black, and wouldn't drain at all. So then I ended up back in the hospital, emergency surgery, and then they took a laser and burned the black tissue off. And I think they thought there was still some blood flow, so they were gonna burn off the necrotic tissue and then see how it did. But what happened was it ended up getting hard. This whole thing is supposed to open like a rectum, you know, it's supposed to open and close and be relaxed. This thing ended up being very hard, and I had to always put a tube in it to drain it. So that's really hard on the patient to have to do that. Well, then pretty soon it just completely stenosed. Do you have that picture of the small one? Yeah, I'm sorry, that's probably not a good picture. But anyway, you can see, it just kind of, it went back inside. On the scan, there was no ability for stool to come out. I ended up with 4 separate bowel obstructions. And so they took me into surgery the next day to put a new ileostomy, and they went into the sleeve site.
You have a little wound
Yeah, I
here.
have a little wound that we were packing. I was here last semester.
Month.
Last month, yeah. And we were packing this little abscess here. So you can go to the new stoma. Okay, there's the new one. Now you can see the difference with that. If the tissue's nice and pink, and that's what you want to see after surgery. These sutures dissolve. They dissolve. Now this is right after surgery. Do you want to grab that one with the gauze on it?
Oh, that might be way,
There we go. Bring my dog in there. Okay, so look, now this is after surgery at home. So you still have a whole healing process that goes on with this stoma. And I got a big blister here and some sutures that didn't dissolve correctly. So that takes a lot to be able to take care of that at home and manage it. That's why your job is really important with the patient. I'm going to talk briefly about the patient care aspect of it. You know, in the hospital, there's stoma nurses. Well, they may come to the floor and get, you know, mark the patient for the surgery, and they may come in and get some appliances, but really they're in and out and they've got a lot of patients they have to see. So you guys are really critical to that process of seeing how that patient's going to do with that ileostomy. Now, some of these people are young, 20, 30, 40 years old, and they're ending up with a permanent ileostomy.
I saw a 9-year-old with gradually all the bowel was removed and because of Hirschsprung. So, yeah, she did gymnastics and.
Right? And I have a friend of mine who has colon cancer, and she's going to have an ileostomy. And her learning curve is, I mean, she doesn't learn. I said, hey, I got equipment, I can show you this, I can show you that, you know, I'm all excited, and she's like, I don't want to hear about it. So they're going to be tough in the hospital, and the biggest thing is you got to get them hands-on, because their stoma is going to stay perfect, like it is in the hospital when it's freshly done. You're going to get problems like this and healing issues. Now that is all healed now, but you got to order equipment, you've got to be able to watch that site. So in the hospital, you guys, if you see somebody who's like, they don't want to touch it, because they'll come to the ER to have it changed. They don't want to touch it. That's how upset they are. So if you're seeing that, then the doctor needs to order a consult for them for psych or counseling or someone to get in there and talk to them, even if it's you. But they got to get hands-on. You are going to be the first people to see, are they coping or not coping with it at all? And if they don't want to touch that ileostomy or their colostomy, that it's a concern, because that will not heal. It will get infected, there'll be abscesses, and then they're going to be in trouble. So, so that's a very important piece, I think.
It kind of looks like the tissue is sloughing a little.
Yeah.
Right?
This is an ongoing process. If you want to go back to some of those other ones. Yeah, so you can see here where it's developed a coating, that's after surgery too. So it develops these, you know, different kinds of healing through the healing process. Eventually it'll look really nice, and, you know, it'll hopefully be, you know, easy to care for, and it won't have any openings. But you can get ongoing skin issues from some of the appliances that the patient can be allergic to or something. So, and abscesses are real common. Fungus is really a common problem because it's wet and it's moist in there. So patients really need to get educated about And that's where you guys come in. And you know, you guys don't have to know everything about all of this stuff, because you can call the stoma nurse and say, you know, could you come up and, you'll go over this or whatever. But you should know some of this so you can kind of get them started with it.
You said you've had problems with sutures dissolving?
Yeah, sometimes the sutures wouldn't dissolve and then they would create an abscess.
Okay.
So I'm gonna go back to when I was in the hospital and some of the complications I had, and then I'll go back to this stuff. Is that okay? So, in the hospital, you wanna go to the edema one? There's my dog. Oh, go back to my dog. Jeannie, that's my rescue dog. She has one lung. She came from a puppy mill. Somebody kicked her. All her ribs were broken and she ended up with one lung. Look at her now. Isn't she look great? We healed together. Actually, I adopted her around the time I got out of the hospital. So we were both kind of went back around. Okay, so enough of that. We'll go back to, okay, so in the hospital, and I'm going to cover a little bit about nurses and their perceptions and how they should be advocates for their patients. So after surgery, I knew there was some stuff going on that wasn't correct. So first of all, my abdomen was getting bigger, and I kept saying to my nurses, my abdomen's getting bigger. I mean, it was getting huge. Then I had all this edema from underlying infection, which we found out later. Then I started having trouble breathing, and the nurses were dragging me to the bathroom, and I'm like, I can't take a full breath. I'm like this going to the bathroom. I can't stand up straight. All of this is hurting really bad. So they would give me maybe some pain, Percocet or something for pain, and then they would lay me down, and then the nurse would come in and she would check my sats and be 90%. Now I'm not that old, okay? 90%. So she'd go get another piece of equipment. Then she'd put it back on again, and then she'd say, well, I'll check it in a half hour. Then it goes to 89. Then it goes to 87. So while all this waiting around is going on, people are just kind of hemming and hawing, what ended up happening is I had severe atelectasis in my lung, and then I had a huge abscess in my abdomen, which caused a major infection. And then we have a fluid shift with infection, so then I had all that edema. But what I found was that people were second guessing. Well, it was kind of like they didn't really want to believe there was an issue going on. And I think that's kind of a disservice to the patient, because I think when a patient's having problems, it's not going to become apparent right away, but you're going to see trends. And then my fever, okay, so I had a fever of 99, 99.4, they keep checking it. Well, maybe it's the equipment, let's go check it again. And then it's 103. Then at midnight, I'm going down for a drain, basically. You want to go to that picture of the drain. There we go. And that is Professor Beyer is a what?
What kind of drain is this, folks? Okay.
Yeah, now listen, you guys. This looks like a rubber thing, and it's like no big deal. Okay, the drain that they put in interventional radiology is like a harpoon. It's a big corkscrew. It's a wire. So this goes on to the end of it. So it looks like a drain that isn't like a big deal, but it is because it attaches to something that's pretty traumatic for the abdomen. So consequently, I had lots of pain. Well, I had nurses coming in. Well, you can't give pain medicine for another 3 hours. Well, I've got that in my abdomen. I've got the ileostomy. I've got an active infection. So it really took a lot for me. Good nurses would come in and say, that hasn't worked, I'm calling the doctor. We'll get your pain under control. Because it's really not okay to have a pain scale and you're asking the patient what their pain level is and then walk out of the room and not do anything about it. Their pain's I kept saying, my pain's a 6 or a 7. Okay, well you can get something in a few hours. That's not acceptable. You don't want a patient sitting there at 6 or 7 for a pain level. And fortunately, they didn't like our room, because I had nurse friends coming in to visit. And so a friend of mine is a director of nursing. She said, that's not acceptable to have pain levels like that. The state came out with those parameters to make sure that we control people's pain. So that doesn't mean you ask them and go, oh, you're a 7? Well, that's good. Good for you. You know, you gotta, if what you're doing isn't working, then you gotta call the doctor and, you know, get something more. And really keep track of that. Go back in and check with the patient. Did that help? If it didn't help, because at one point during this whole process, I had to be put on a pain pump. You know, then I would fall asleep and there wasn't the basal, so I wasn't pushing it. So then I would have a nurse come in, well, you're on a pain pump. What do you want me to do about it? You know, kind of thing, you know, about your pain. But I was falling asleep and I wasn't getting, so then they had to put a basal rate on. But, so it's really important to not just, you know, not be checking equipment. You know, I mean, if your patient's healthy and they're pink and everything and their SATs are 75%, well then, yeah, maybe it's an equipment issue. But when you see subtle changes, don't just walk away, wait for it to get bad, where it's obvious. Subtle changes are really important to follow. Don't you agree?
Yeah, if your pain would have been managed, you wouldn't have had atelectasis. Tell them what your baseline IS was and what it went to.
Yeah, my incentive spirometer was 2,400 and went down to 1,000. Literally could not
Because of the
do any better.
distension.
Because of the
and
distension,
pain.
because of being unable to breathe. And I sat that way, you guys, for 2 days. 2 days in the hospital. And I knew that something was brewing. Now, I'm not saying that's anybody's fault. It's just that I think that people needed to get more aggressive. Even the doctors and probably the nurses. And sometimes you guys are the squeaky wheel. You know,
Because you were telling them, I feel feverish.
I feel feverish, yeah. So, you know, and your patient, listen to your patient, because they'll tell you. Like when you go to put an IV in, patient will say, they never get anything in that arm. Well, that's the same with me. They never get anything in this arm. What happens? The nurse goes into this arm. She can't get anything. Is that a surprise? No. Your patient knows. Your patient knows. Listen to what they're telling you. And be their advocate and ally yourself with the patient. And you'll get much better results with the patient. You'll get them more cooperative if they know that you're advocating for them. Because patients know when people are busy or don't care, you know, or act like they don't care. They get very frustrated with that. So I think that's a big deal.
As I'm looking at this drain, didn't you say that there was quite the odor?
Yeah, there was a lot of odor with it at the beginning, and then it started to settle down as the infection.
There was more serosanguinous, a little cloudy, and there was more serous.
Yeah, as time went on.
And you had that how many days?
About 4 or 5 days, yeah.
And you were on big time antibiotics, I'm sure.
Yeah, lots of antibiotics, and lots of trying to get my lungs to recover. Because I was so compacted down with the edema, and not really being able to move much. And that's another thing, if your patient can't move, their side effects, their problems are gonna go way up if they can't move. Like I couldn't hardly walk, my abdominal area was distended, I couldn't breathe, and then pretty soon I was taking half breaths, and I told my nurse, I said, I can't take a full breath. I can't breathe. Wow, that's a big deal. If your patient can't breathe, you gotta be concerned about a clot or something going on with them after surgery.
Which
That-
they did a scan for you to see.
Yeah,
if
they
there
did,
was-
yeah. Eventually, they did. But I sat there for a while just not being able to breathe. Yeah, and I think they were kind of thinking, well, you know, she's been through a lot, she's having a lot of pain, let's take care of the pain. You know, try to take care of the pain, but nobody was really looking underneath any of that, you know.
And the surgery recovery would normally be how many days in the hospital?
Probably about, you should be out of the hospital about 3 or 4 days. Both surgeries, I was in for a couple of weeks. Yeah. Now, it's very hard to eat after a surgery like this. A lot of, and I don't know why this is, but a lot of what you eat comes out the same way you ate it. So if you have tomato soup, you're draining tomato soup from your bag. And it's so hard on your appetite. I just could not eat for quite a long time. And a lot of patients won't want to eat. So go ahead, yeah.
Were there certain things you eat that would irritate the stoma?
Yes, any kind of bulk vegetables, small intestine, that's at the beginning of digestion, so it's not gonna digest any of that. And it'll actually just hurt. Like one time I ate carrots, thought, well, if I chew them up good enough, it really hurt my stoma because I could feel those carrots coming out, and they collect and they can also obstruct. So it's very important that you not eat, your diet has to change quite a bit. You can't really eat bulk vegetables. Lettuce will not go through. That'll obstruct the liquid. I had eaten some sausage one time with these little yellow pellets of
Mustard, right?
Mustard, and they were all bulked up in the stoma and blocking the stoma. So you have to be really careful about what you eat. My diet is pretty much, I can have some breads. I don't eat a lot of carbohydrates because my bag fills up really fast. That stuff digests very quickly, and if I'm going somewhere or doing something, I don't want the bag to empty in a half hour. So I eat a lot of eggs, some meat, but protein is really a great thing to eat because it takes a long time to digest, and your bag isn't filling up all the time. So, but you do have to be careful about those bulk. Popcorn is completely out of the question. Maybe some chips you can have, but you have to just really be careful.
Cooked vegetables okay or not?
Cooked vegetables are okay, yep.
And coffee, what does that do?
Oh, coffee, yeah. You know how you hear about coffee? You guys are big, I bet you a lot of you are big time coffee drinkers. I am, and they're like, I used to go, for crying out loud, who cares that there's not that much acid in coffee? I'm drinking all this coffee. Well, I found out with 1 cup of coffee, my whole bag fills up twice within 20 minutes of bile is produced. So when I drink coffee, I am emptying this bag like there's no tomorrow. So that's bile from the coffee. So that'll tell you how much, so when you're dealing with your patients who have GERD and things like that, you'll be going, coffee is really a problem, So that was interesting because you do get some insight on digestion.
How much weight did you lose?
I lost about 30 pounds for each surgery. And gradually you'll get that back, but it takes time. And usually for the first month or 2, patients don't feel like eating. Your appetite is just not there. So the recovery time takes a while. Let me get into care at home. Do you want to, go back to that abdominal binder. So your patients in the hospital, now the stoma nurses don't even recommend this, but I asked for it. These muscles are really sore. So and I wear this abdominal binder, but you can get an abdominal binder for them and have them put that on real lightly, and it'll offer some extra support. They can't have it tight because the bag, of course, needs to empty, but absolutely offer stuff like that. The other thing that I did use at home, I love this. People say, this is a rice pack, and I put it in I had never heard of these before I started working at Quiet Oaks. But what's nice about this is the weight. For some reason, the weight helps me. I use this all night long for pain. And you can put it around the stoma and get that heat on there or put it across, and that really helps. So you can recommend this to patients. A heating pad is okay, but this kind of really falls in place and will get to those areas that you need it to get to. So I'm like warming this up all night long. So these are nice to have. Okay, so as far as equipment, you can go to that plastic container thing. Okay, so in my bathroom, I'm set up, okay? Now, that's important to tell